This presentation is on the family nursing care of the Porter family and one of their members' recent diagnosis of gestational diabetes by Stephanie Cartier, Carly Chalison, Priya Kadiath, and Jessica Sisson. Natalia is 27 weeks pregnant and was recently diagnosed with gestational diabetes mellitus, or GDM. She has been conscientious about going to prenatal appointments and about diet during pregnancy. The diagnosis came as a shock to her and her husband because there were no concerns previously expressed by the healthcare providers in past visits. What is GDM? GDM is a metabolic disorder of pregnancy that affects nearly 7% of pregnant women. Screening for gestational diabetes occurs during the second trimester, which is 24 to 28 weeks gestation, when glucose and insulin demands significantly increase to support the needs of the growing fetus. Untreated GDM can result in complications related to preterm labor, stillborn birth, fetal respiratory and metabolic issues, and large for gestational age infants. GDM may increase the risk of developing type 2 diabetes after pregnancy. Higher incidence of gestational diabetes occurs in women who are poor, less educated, of non-white ethnic backgrounds, and/or are obese. It is clear how a stigma can be developed about gestational diabetes when looking at these incidence rates. Risk factors include a family history of diabetes, previous stillbirth, pregnancy with macrosomia, obesity, hypertension, glycosuria, and maternal age greater than 25 years. Natalia is one of the many women who was diagnosed with GDM and had none of these associations. According to Loudermilk et al., more than half of all women diagnosed with GDM do not have these risk factors. This fact is significant when counseling families and women who are newly diagnosed with GDM to reduce perceived stigma. Here is a brief summarization of Natalia and Matthew's family. They currently reside in Southern California, which is a great distance from both of their families. Natalia is originally from Colombia and moved to the United States with Matthew just after getting married 2 years ago. Matthew and Natalia both work 40 hours a week. Matthew is a Navy captain and Natalia works at a spa. Both Natalia and Matthew's jobs have influenced them positively with regard to their health. They also have a lot of support from their coworkers and friends. At this point in their lives, Natalia and Matthew are in Erickson's developmental stage of intimacy versus isolation. Natalia and Matthew are discovering the changes associated with a growing family along with new and concerning health issues. Natalia is learning to adapt and cope with these new changes in a country she is not native to with limited fluency in English. Natalia and Matthew's parents are in Erickson's developmental stage of generativity versus stagnation. Esperanza and Jorge have already experienced becoming grandparents, and now Linda is entering a new phase of her family growing. Natalia and Matthew have a vast amount of familial support to help them through their pregnancy, both in the United States and in Colombia. However, since their parents are so spread out, sometimes they feel as if they only have each other. Natalia comes from a large family. Her parents are Esperanza and Jorge. She also has 3 siblings and 3 nieces and nephews. All of her family still lives in Colombia. She moved to the U.S. to be with Matthew. She has assimilated to American culture well. She is very health conscious and is disappointed about the diagnosis of GDM. Matthew is from a smaller family. He is an only child and his father died when he was 18 years old. He now only has his mother, whom resides in Northern California. Natalia has been a great support to him and has become his family. His mother, though far from him now, will come to live with them once the baby is born. Matthew is very supportive of Natalia. He is nervous about the GDM diagnosis and wants to help Natalia in any way possible. Natalia is assimilating into American culture. However, she still participates in cultural activities from Colombia. Natalia enjoys cooking traditional Colombian food for Matthew and is teaching him Spanish while he is helping her with her English. Matthew and Natalia were both raised Roman Catholic. They go to church every Sunday and would like to raise their child with the Roman Catholic traditions as well. Natalia and Matthew have developed a family routine over the last 2 years of their marriage. Both Natalia and Matthew go to work 5 days a week. Typically, they are both home by 5:30 p.m. and they share dinner together. Natalia and Matthew alternate cooking and share household responsibilities. Every Sunday, they attend Catholic Mass in their community and go to the park after for a stroll. Natalia speaks with her parents at least once a week. As Natalia moves further along in her pregnancy, Matthew and Natalia are becoming more and more prepared for the baby. Every night, Natalia reads the baby books, and Matthew talks or sings to the baby. Once Natalia has the baby, they understand their routine will change. Natalia's mother-in-law wants to come live with them to help with the baby. Natalia will have 3 weeks maternity leave and then return to work part-time. Natalia and Matthew have a loving, supportive relationship. They are cognizant of one another's strengths and weaknesses and build each other up. Natalia is very excited to be a mother. She hopes to raise her baby as her mother raised her, with morals and values congruent with their culture and faith. Matthew is thrilled to be a new father. He does not care if it is a boy or a girl. He just wants a healthy baby whom he can raise as his own. All of the in-laws are very supportive and can't wait to be involved in the baby's life. Natalia and Matthew have many strengths. Their pregnancy was planned and they are very excited for the new addition to their family. They both have secure jobs, leaving them financially secure. Both Natalia and Matthew are physically active. Natalia goes to Zumba 3 times a week with her closest friend. Matthew exercises every morning with his Navy buddies, and they take walks together on Sunday in the park. They also have a great amount of support from their families and friends. While Natalia and Matthew have many strengths, they also have a few challenges to overcome. Communication is sometimes difficult between them, as Natalia sometimes has trouble speaking English, and Matthew sometimes cannot understand her. Natalia's pregnancy in itself is a developmental milestone that can contribute to disequilibrium in family functioning, roles, and identity. Along with the pregnancy, Natalia has been diagnosed with GDM, for which the family must learn how to manage care. While they have a variety of support at home, the lack of proximal familial support can be taxing, as Natalia sometimes becomes homesick and Matthew also misses his mother and father. Lastly, Natalia is still assimilating to American culture. Matthew has been very helpful, but assimilating contributes to stress on occasion. Natalia primarily speaks Spanish, but has grown in her English skills since she has been living in the U.S. and working. Matthew knows some Spanish, but not very much. Matthew finds it difficult to explain some things to Natalia when he does not have the correct word or phrase to translate something new. They both understand their language barrier can sometimes cause difficulties in their communication. Matthew and Natalia do their best to communicate with each other in a healthy and respectful way. They're open and honest with expectations and feelings. To care for the Porter family, we drew from several nursing theories and frameworks. The primary guiding theory is the family health model. We also utilize theory from strengths-based nursing concepts, empowerment theory, the nursing process, and the Friedman Family Assessment Model to inform the provision of care for the Porter family's experience with gestational diabetes. The Family Health Model, created by Sharon Denham, is a framework through which nurses can assess, provide supportive interventions, and evaluate outcomes for families needing illness and health promotion care. It is an ecological model that emphasizes biological, holistic, and environmental components that affect health and family health. It focuses on connected family processes, interactions of external family environments, and family routines. We decided to use this model because gestational diabetes requires complex self-management and support from all family members to ensure the health and well-being of mother, fetus, and family. Understanding the family dynamics, especially routines, and external environmental family factors will help the nurse to empower family members to identify a self-management plan that promotes the best outcomes. The family health model uses 3 domains: contextual, functional, and structural, in which nurses perform assessments, plan care, provide nursing actions, and evaluate outcomes. These domains allow nurses to assess factors that occur within and outside of the family that affect family health. The first domain considers the contextual aspects of the family, such as family characteristics, the household environment or family culture, membership traits, traditions, and external environmental factors that affect the family, i.e., neighborhoods, community resources, demographics, and socioeconomic factors. The second domain considers the functional aspects of family, such as an individual member's values, coping, spirituality, resilience, and roles. The second domain also considers family processes such as communication, caregiving, and change. Finally, it also considers factors that affect family processes such as cohesion, resilience, and boundaries. The third domain addresses the structural aspects of family and family health, such as family routines, rituals, and habits that pertain to 6 domains of family health routines, including self-care, safety and precautions, mental health behaviors, family care, illness care, and member caretaking. We are using the Add Pie structure to implement the family nursing process for the Porter family. We will go into greater detail with each step in the coming slides. The family health model can be applied to the assessment phase of the nursing process by utilizing family health assessment tools. Assessment is an essential tool in the family nurse's toolkit in the delivery of family-focused nursing care. To fully understand the family's most important concerns, nursing assessment should utilize family interviewing and therapeutic communication techniques that facilitate the sharing of the family story. According to Denham and colleagues, the 15-minute interview can be utilized to gain initial information about the Porter family's most pressing concerns, feelings, and needs related to their health situation, and aid the nurse in identifying strengths. Perhaps most importantly, the 15-minute family interview can be used to build a trusting, collaborative, and mutually therapeutic relationship between the nurse and family. For a more comprehensive assessment that integrates the domains of the family health model, the nurse can use the Friedman Family Assessment Model. To help guide the nurse that is using the 15-minute interview to establish rapport with a family, these therapeutic questions are recommended. The genogram allows us to understand familial patterns and pertinent family medical history. Natalia and Matthew have a variety of influences on their life and health. The majority of Matthew and Natalia's relationships are strong. They have supportive families, friends, and coworkers. They are financially secure and both hold secure jobs. Matthew loves his job and will continue it until retirement. Natalia feels blessed to have a job, but feels she would like to do more. She hopes to one day go to school and secure a more preferable career. They have strong faith and go to church every Sunday and feel the support of their parishioners. Natalia's health is typically great, but now they are both very concerned about her health. The Friedman Family Assessment Model includes an assessment about the family's identifying structural, functional, and environmental data, as well as family stressors, family coping, and family strengths. Data gathered using this assessment model is in alignment with the 3 domains of the family health model. The nurse or clinician can use their discretion to decide which areas require the most attention. Initial family concerns identified during the 15-minute interview, understanding of the factors that affect effective coping with the condition, and clinician judgment based on experience and expertise can be used to tailor the assessment tool to the family. Using the assessment tools previously described, data is thematically clustered into domains based on the family health model to identify family needs and to collaborate with the family. This is done to establish goals, develop a plan of care, implement interventions, and evaluate outcomes. Both psychoeducational and relationship-based nursing interventions have been selected to be implemented. Evidence shows that these interventions have the capacity to be more effective than medical care. This is because medical interventions tend to treat the symptoms and all too often ignore the source of the behavior or do not discuss implications for the family. The following interventions will focus on fostering a relationship of trust between the patient and the family, exploring relationships within the family, and assessing behaviors and lifestyle to provide culturally appropriate education as needed. The first nursing intervention is to assess current family routines related to health, exercise, and nutrition, and perceived and actual barriers to adapting healthier routines. The rationale for this is GDM can be managed by modification of lifestyle routines and behaviors related to diet and exercise, which require attention to family routines and rituals by the nurse. Research indicates that the strongest predictive factor of maintaining prenatal exercise routines is spousal participation and encouragement. Earlier in our discussion regarding the 15-minute interview, using family interviewing and therapeutic communication was touched upon as a cornerstone to family nursing. Notice that this interview is not focused solely on Natalia, but the family unit, including her husband in the discussion. The nurse will use a variety of tools while assessing, including open-ended questions, listening, informing, and giving feedback. According to Denham and colleagues, effective communication happens when questions are asked, when information is given and understood, and comfort is provided. The second intervention is to assist and commend the Porter family in identifying strengths in current family functions and routines that will promote healthy pregnancy outcomes and minimize GDM complications. The rationale for this is a strengths-based family nursing approach focuses on strengths, competencies, and resources to foster empowerment for family members to take initiative for attaining and maintaining family health. For example, some strengths of the Porter family include Natalia's Zumba workouts, joint walks in the park on Sundays, family meals, a desire for a healthy planned pregnancy, and family cohesiveness. The third nursing intervention is to provide culturally and language appropriate resources for gestational diabetes management that allow the Porter family to develop a health maintenance routine that promotes wellness. While providing resources to Natalia and her husband, the nurse should seek to maintain a culturally sensitive attitude by tailoring all education to the expressed unique needs of this family. This includes offering the service of an interpreter if desired, even though Natalia is able to communicate in English. The rationale for this is that diabetes educators caring for individuals with GDM from disadvantaged backgrounds were able to most successfully help women when they saw opportunities to connect with women in their care and to make the educational content understandable and meaningful. Providing resources that incorporate culturally relevant information and food choices will enhance women's uptake of gestational diabetes lifestyle changes. For example, encouraging Natalia to add more vegetables to the family dinners may be effective. Families that are diagnosed with gestational diabetes often have little time to adapt to the diagnosis before being expected to participate in a treatment plan. Nurses who think family should understand that a family-centered and tailored approach should be utilized to care for families with GDM. Nurses who think family acknowledge and seek to bridge the power imbalance which often exists between those providing care and those receiving care. These nurses are able to do so through being unassuming and maintaining an attitude of cultural humility. Nurses who think family should recognize that many complex factors will affect how any given family will experience gestational diabetes. Assessment and interventions should be individualized to meet family needs and priorities in maintaining and promoting wellness. Diabetes requires that the family make lifestyle changes to manage the condition, prevent complications, and promote long-term health. A strengths-based nursing approach can be used to help the nurse identify family strengths such as communication and routine that promote health, provide commendations and positive feedback to families, and engage and motivate families to adapt and adopt healthy lifestyle changes. More research is needed to understand how families experience a diagnosis of GDM and how the diagnosis affects family dynamics. Research should focus on understanding how family structure, function, and context influences the management and outcomes of gestational diabetes. This concludes our presentation of family-centered nursing care for the Porter family. These are the references we pulled from in our research. Thank you for taking the time to listen to our presentation.